Welcome to the Mountain West AETC Project Echo. I'm Kent Unruh, and I'd like to turn it over to Dr. Brian Wood, our medical director, to introduce our guest.
Thanks, Kent. I don't think Dr. Harrington needs any introduction. You know Bob very well. I will just turn it over to Bob to review some of the more important abstracts from ID Week in New Orleans.
Great.
Thanks, Bob.
Thank you, Brian. Yeah, it was a good session in New Orleans. In fact, I ran into at least one of our Echo neighbors. Bill Muth was there. I don't know if other people were at IDSA. If you were and I didn't see you, I'm sorry about that. But I did run into Bill, and we went out to dinner one night. That was fun. So the things that I'll cover, there was a fair amount of major talks or even a plenary about inflammatory disorders and HIV and heart attacks, strokes, non-AIDS defining cancers, but it wasn't new data. It was just kind of reviews of the inflammatory conditions that can develop in HIV. So because there wasn't any new information, I didn't really cover those talks in this presentation. What I will review is 4 or 5 abstracts that caught my attention. They were actually oral abstracts, and then there were a few posters that I thought were worthy of mention. So I'll look at something by Joe Aron on the management of low-level viral blips, which we talk about a lot at Echo sessions, and he's providing some information on that. One study, the ARIA study of antiretroviral therapy done only in women, so I think women are often underrepresented in many of the treatment studies, and this one was done just for women, so worth talking about. Some interesting data on omega-3 fatty acids. One abstract came out of UW on the reservoir decay, and then 3 abstracts that I think deserve some honorable mention, but they're kind of small with short follow-up, but they're kind of provocative in their own way. So the first one, this was an oral abstract, 948, presented by Joe Aron from North Carolina, retesting of suspected low-level HIV viral load blips, a new paradigm to prevent extra clinic visits and unnecessary patient anxiety. So the hypothesis that Joe and his group were testing was that many low-level plasma viral loads may simply represent variability in assays and not represent any true virological failure. So the methods that they used to investigate this was they first obtained 50 aliquots of diluted WHO standard, I don't know if it must be plasma that's spiked with HIV, with viral loads that were less than 200 copies per milliliter. And then they got 4 to 6 plasma samples from 4 patients at North Carolina who had viral blips of between 50 and 200 after having been undetectable at least one time. So those were the samples that they were using. And then they retested, not the patients, they retested the samples, those exact samples that gave the values previously, with a Cobas AmpliPrep TACMan2 assay. It's a Roche-based assay that was run at Covance Laboratory, so a send out to Covance. And these are the results that they got. So for the WHO standards, they had a bunch that had a copy number of 17 copies per mil. And on retesting the same sample, almost 20% of those were over 50 copies. And on WHO standard samples that had a copy number of nearly 40, 2/3 of those were over 50 on retesting. And for the patient samples, these were samples that came in at greater than 50 copies, but less than 200. When they retested 15 of those 16 plasma samples from their own patients, 15 out of 16 were less than 50 on retesting. So these were, I think the key point here is that these were not bringing the patients in and retesting them a month later. This was retesting done on the identical specimen that gave the low-level viremia in the first place. So this just suggests that when we get those low-level viral loads, it probably is simply representing some variability in the assay rather than representing breakthrough viremia. So I think Joe was presenting this as kind of something that we might consider doing in the future, is retesting the same sample in patients that have low-level viremia, and if it comes back at that level or even lower, if it's less than the threshold, then that would obviate the need to bring the patient back into clinic and to retest them again. So interesting idea. I don't know if we have access to to leftover plasma from when we have a positive result, but if your hospital or laboratory keeps those specimens for a while, then you could go back and ask them to retest that same sample and maybe prevent the patient from coming back to clinic for a retest. Okay, so the next abstract was also presented as an oral presentation. This was 949, the AREA study. It was presented by Dr. Hagens, an African-American physician from the South. I can't remember where exactly. So this study looked at Triumec, dolutegravir, abacavir 3-TC, versus boosted atazanavir plus Truvada in HIV-infected women. So this was an international study. I think it were 9 or 10 separate countries, including the United States. Patients were stratified by HIV RNA level and CD4 count, so that within different strata they were randomized to one of the two treatment arms to make sure that it was equal at all strata. There were 500 patients, median age of 37, and half were Caucasian and those of African heritage. So this was great in that there were a lot of African patients in this study, kind of unlike some other studies which are overpopulated with non-minorities. And the results were that the dolutegravir arm, the Triumec arm, was superior to boosted atazanavir, and the difference was due to both lower rates of discontinuation and fewer virological failures in the dolutegravir arm. And the data are on this slide. So overall, 82% on the dolutegravir anchored arm were undetectable, meaning less than 50. I think this is 48-week data, compared to 71% with atazanavir, for a true difference of 10% that was statistically significant. So this met the predefined criteria of superiority. And that difference held up regardless of your race. White, African heritage, and other patients all experienced the same benefit. So kind of a good study because it was only women, and it included, in the United States, our minority populations, showing superiority of dolutegravir over boosted atazanavir. So the next study was another oral presentation. This was a randomized control study of omega-3 fatty acids in HIV, looking at the long-term effects, although the results were not very long-term. We can talk about that. But its effects on lipids and on vascular function. So the setup for the study were that patients were randomized to 4 grams, so a hefty dose of fish oil, 4 grams per day versus placebo. The primary outcomes were effects on triglycerides, high-density lipoproteins, and C-reactive protein, the latter as a measure of the inflammatory condition. And secondary effects were on brachial artery reactivity and arterial stiffness. The latter was measured with a pulse wave velocity. So with stiffer vessels, you have a faster velocity is transmitted. With more flexible, pliable vessels, the velocity is less rapid. Patients, there were 117, half got omega-3 fatty acids and half got placebo. Median age of 51, 20% women. Almost all were virologically suppressed with excellent CD4 counts. And these are the data. So they say long-term effects, but the long-term effects, it was only 24 weeks. But there's the expected drop in triglycerides. I think everybody knows that omega-3 fatty acids can decrease your triglycerides pretty effectively. There was no change in high-density lipoprotein levels, but there was a drop, a statistically significant drop, in C-reactive proteins of 0.3 compared to a rise in the patients that were treated with placebo. There was no difference in brachial artery reactivity. I'm not sure what that is. I tried to find out and couldn't. But there was a decline in velocity of carotid femoral pulse wave velocity, so more pliable vessels, whereas there was a rise in that, stiffer vessels, in the patients on the placebo arm. These were only at 24 weeks, and any vascular effects of this dietary modification you might think would take longer to develop. So I would view the brachial artery and the pulse wave velocity things as preliminary data. But it looks like there's real changes on triglycerides and maybe real changes on C-reactive protein levels as well. These are just the graphs showing the heavier lines are the omega-3 fatty acids, so a drop in triglycerides, and then you can see the CRPs were kind of flat or low in the omega-3 fatty acid treatment group. So reducing triglycerides limit chronic inflammation, and they may improve vascular function. Okay? The last oral presentation that I reviewed is something that came out of UW. Jonathan Golub, one of our fellows, presented this. This is a reservoir, HIV reservoir size and decay in 114 people, so a good-sized study, who had been suppressed virologically for at least 7 years. So this is the study setup. There were 111 patients who contributed almost 500 PBMC samples to the HIV specimen repository that we maintain here at the university. Now, those PBMCs were assayed for total cellular DNA using primers that amplified both regions of GAG and POL, so two distinct regions in the viral genomic, you know what I'm trying to say, the provirus, thank you, and normalized those values to genomic DNA and CD4 count at the time of collection. So all patients had been, it was 5 years, not 7 years, had been suppressed virologically for 5 years before they started contributing specimens to the repository. And then we measured the level of the reservoir at serial times after they'd been suppressed and looked to see what correlated with the size of the reservoir and the decay of the reservoir. So these are the patients, 114 of them, 111 were qualified for analysis, age of 48, mostly males, mostly white, but they had been on protease inhibitors, non-nukes, and integrase inhibitors, a fair number on all of those. And the actual median time that they'd been suppressed prior to making contributions to the repository was 8 years. T-cell counts were excellent, and the median follow-up time was 1.5 years. So we looked at risk factors for, or correlates of the reservoir size, and we looked at risk factors for getting HIV, and those had no effect on reservoir size. ARV exposures, whether they'd ever seen an NNRTI or protease inhibitor or an integrase inhibitor, and that had no effect on the reservoir size. And there was also a time analysis, so number of months on an integrase inhibitor or a protease inhibitor or a non-nucleoside drug, and that also had no effect on reservoir size. Age did. So if you were older, then you were more likely to have a higher reservoir size than younger people. Sex and race had no effect. And then because the reservoir did decay over time, then time also was isolated as correlating with reservoir size. So the age at the time that we started measuring the reservoir made a difference, and then the reservoir did decay over time. One thing that Jonathan was interested in is what is the half-life of the reservoir in this study. So this is some math, don't freak out. Log 10 divided by the coefficient, which was on the previous slide, of 0.025. And then if you do that calculation, the half-life of the reservoir is 12 years. So this is longer than what other people have reported. Bob Silicano's group and others suggest that the half-life is closer to 4 years. They used a different assay of the reservoir size. They used a viral outgrowth assay, which probably underestimates the size of the reservoir. This was a DNA proviral assay, which probably overestimates the size of the reservoir. But the decay rate should not differ. Okay, those two different techniques will affect the size, but it shouldn't really affect the rate of decay of the reservoir. So this was kind of new information. This is just a picture of one person, a representative person, who had a high viral load when he was untreated, and then his viral load comes down here. So at all times, remember, these people were clinically suppressed, so they had to have a viral load less than 40 or 50 the whole time, so they're clinically suppressed. This person had a blip here, so they had quantifiable virus early on before they were treated. They had one time where they also had quantifiable virus, but then they had lots of values that were less than 40, but not detectable. So they had detectable virus, but was not quantifiable in these periods. And then this person had a time period where they finally became not detectable, and they are no signal at all from their plasma viremia. So we looked at these three different groups of people: quantifiable, detectable but not quantifiable, and not detectable at all, and looked at what was the half-life of the reservoir decay in these 3 different groups of people. So remember, for the entire cohort, the half-life was 12 years, 144 months. If you looked at the people that were always undetectable in the follow-up period, so they had no signal at all in their plasma, then their half-life of their reservoir was 64 months. If you had detectable but no blips, then your half-life was pretty close to the entire cohort, about 12 years. And if you had blips, then the half-life was even longer. So all of these people, remember, were undetectable. They did not have their antivirals change. They were clinically stable. Their T cells are 700. At echo sessions, we don't pay too much attention to these low-level viremia or these blips. We just forge ahead. And they probably don't have much clinical meaning because people remain immunologically well and clinically well. But they may actually have an effect on the size of the reservoir and the decay rate of the reservoir. So there may be consequences to having low-level viremia or viral blips when you start talking about curing people of HIV. So conclusions were the regimen, gender, race, and HIV risk factor did not correlate with size, but age did. The half-life for all patients was about 12 years, and if you were always undetectable, the half-life of the reservoir was half of that at 64 months. So those were the oral presentations that I thought were worthy of telling the group here. There were some posters that I thought were provocative and interesting. There were a few of them that I think we have time to do that, so we'll go over those. The first one was presented by Eric Darr, poster 952. This was a sub-analysis of older adults in a TAF switch study. So a subgroup analysis of a randomized switch study at 48-week data. Patients, again, for this sub-analysis were over 50, randomized, double-blind, controlled study in suppressed patients who were on a variety of different drugs but switched over to TAF FTC from tenofovir FTC. The third drug could have been a variety of things, which stayed constant. Percent of individuals who remained less than 50 was 96% in the TAF group and 94% in the TDF group. The bone and renal effects were better with TAF, and the discontinuation rate was higher with TAF. They didn't go into the reasons for that versus TDF, but I think the point of this presentation really was what's the safety of TAF in people over the age of 50, and it's just congruent with all the other switch studies that it looks like a safe and reasonable drug in an older age group. The next one is poster 1507, GenoSure archive, which we've talked about a few times at ECHO and when to use it. This group in practice had 140 patients with suppressed virus, so suppressed was less than 200 copies. 21% of those individuals had blips and 39% had no historical resistance assays, so about 60% did. And the reasons for getting the GenoSure archives were they wanted to simplify the patient's regimen. We're trying to collect some more data that would validate their simplification. They wanted to confirm that the regimens that they were taking were good. The patients might have been having AEs and they wanted to get them onto a new regimen, or there were a lot of drug interactions and they wanted to get them on a new regimen. So they did GenoSure archives on these 140 people. And these are the rates. So they found these mutations in nukes, non-nukes, protease inhibitors, all classes or any class that showed up on the GenoSure assay, archive assay, only in around 17 to 36%. So maybe around a quarter had mutations that they picked up on the archive assay only, not on the historical assay. There was concordance for in most patients, about three quarters of the time. And there were the occasional mutations that were picked up that were not detected on the archive assay that were detected on the historical assays that they had in the chart. So that didn't happen very often. Whether or not the ones that they picked up only on the GenoSure archive are relevant, because remember, they could be picking up mutations that are in proviruses that are defective, and they just represent nucleic acid garbage, and you don't have to pay any attention to them. But that's what it was. And they did make changes to ARV regimens in 79 out of 140 of those patients. And they didn't have very long follow-up data, only 3 months out. They summed it, 3 months and the number of patients, and they had 500 patient months, but it was only 3 months of follow-up, and 85% of the people in follow-up remained suppressed. So a little hard to interpret it without longer follow-up, but that's the data from the use of this assay in university practice. And then two more. Poster 1519 looked at dolutegravir plus rilpivirine in treatment-experienced patients. Small study, only 14 patients who were switched to dolutegravir rilpivirine after failure. Their prior ART are listed there. 50% had resistance to the prior regimen. 3 patients had NRTI resistance, and 4 patients had 2-class resistance. Short follow-up, less than 6 months, but all patients remained undetectable with a pretty stringent viral load, less than 20 copies. So switching people who had previous drug resistance to a nuke-free regimen, an integrase inhibitor plus a non-nuke, and at least in this small study, it looks safe and reasonable. And then the last poster, 1522, switched to once daily Maraviroc. So remember, Maraviroc is usually twice a day. These 34 patients were previously suppressed on standard ART, and then they switched over to Maraviroc at 600 milligrams once a day instead of 300 twice a day, plus 2 nukes. And at 48 weeks, data from most of the patients, 93% had viral loads that were undetectable. A pretty significant bump in CD4 count over a year, up 94, and there were no AEs. I don't know other people's experience, but my experience with Maraviroc are that it's very well tolerated. So again, a small study early, but once daily Maraviroc seemed to work in switch studies in people who were already suppressed. And I think that's all I had, so I've gone too long anyway, and happy to answer any questions about any of those.